Welcome to the 2020 ASPPH Virtual Annual Meeting. I'm Tony Mazzacci, Chief Advocacy Officer of the Association of Schools and Programs of Public Health. Thank you for joining us. Today's webinar focuses on perhaps two of the most serious and impactful public health crises of our generation. This webinar is titled Opioids and COVID-19, the impact of the pandemic on efforts to prevent and treat opioid use disorders. Before introducing our moderator, a few housekeeping notes. This webinar is being recorded and will be available from the ASPPH webpage within a few hours. We encourage all who are certified in public health to take advantage of 1 hour of continuing education credits conferred by this webinar. When the webinar is over, an evaluation form link should automatically appear on your screen. Please complete the evaluation, as we really do value your feedback. There should be plenty of time for questions and responses. To submit a question, which can be done at any time, simply click on the Q&A button on the bottom of your screen and then type your question in the pop-up box. Now on with the show. On November 1st, which seems like a decade ago in many ways, ASPPH released the report of its task force on public health initiatives to address the opioid crisis. The report, bringing science to bear on opioids, was intended to inform both policymakers as well as all parties to the multi-jurisdictional litigation against opioid manufacturers, marketers, distributors, and retailers. We are pleased to have the chair of the task force, Dr. Robert Pack, with us today to moderate this webinar. Rob is Professor of Community and Behavioral Health and Associate Dean for Academic Affairs in the College of Public Health at East Tennessee State University, and Director of the ETSU Center for Prescription Drug Abuse Prevention and Treatment. Rob is a nationally recognized leader in the field of opioid use disorder and its treatment, and continues to lead a variety of efforts to address the opioid issue in hard-hit regions of Appalachia. Dr. Pack, thank you for moderating this session and for your ongoing leadership on the opioid abuse issue.
Well, Tony, thank you so much for the kind introduction and for being the brainchild behind this webinar. Really appreciate it, and also appreciate you helping to bring the distinguished presenters to the table today. I'd like to introduce our presenters. They are Ms. Ann Haslett, who is Senior Advisor for Rural Affairs at the White House Office of National Drug Control Policy, where she's working across the federal government to equip rural leaders with tools to address drug addiction in rural America. And prior to that, she was Assistant to the Secretary for Rural Development at the USDA. And next, we have Dr. Brandon Marshall, who's an Associate Professor of Epidemiology at the Brown University School of Public Health. And then we have Ms. Regina LaBelle, who's a Distinguished Scholar and Program Director in the Addiction and Public Policy Initiative at the O'Neill Institute for National and Global Health Law at Georgetown University. And she has a portfolio of projects related to the opioid epidemic, as do both of our other panelists. And so we're delighted to have these panelists with us today, and just a conversation where I'll pose some questions to our panelists, and then we'll begin to they'll begin to respond with some comments, and then we'll have some dialogue. I hope you will ask questions in the Q&A, which we'll monitor, and then we'll get to the questions at the end if they haven't been addressed by the comments of our panelists. So with that, I'd like to just say welcome to all three of you, and thanks for being on the call with us today. First, I'll just ask the question: how has the COVID-19 pandemic impacted the epidemic of opioid use disorder that we've been really dealing with for decades at this point? Any opening comments about the impacts? How about this? How about we start with Brandon on this one?
Sure. Thanks, Rob. I would say this is an incredibly perilous time for people with opioid use disorder and folks at risk for overdose right now. In addition to concerns around treatment access, which I think we might talk about later, people with OUD could be facing a dramatically increased risk for overdose during the time of COVID. Counterintuitively, the fact that opioids might be harder to access right now, which we've seen in multiple settings, could actually lead to a surge of overdoses over the coming weeks or months. And that's because after a period of lack of access to opioids, tolerance decreases, which then increases the risk for overdose once people resume opioid use at their previous doses. In addition, I think there are some emerging trends showing that people with opioid use disorder and others with substance use disorders are using other substances such as alcohol and benzodiazepines, which actually potentiate overdose risk when used in combination with opioids rather than decrease it. So I think we need to be looking very carefully at the data as some of these trends emerge over the coming weeks and months, and watch very carefully for some of these increases which many of us, including myself, are concerned about.
Yeah, very good points. Anne, do you have any comments related to how I guess your perception of how the COVID-19 pandemic is impacting the OUD epidemic?
Thanks, Rob, and thank you for the opportunity to be here today. In addition to that question, I'm going to share some things that are more anecdotal in nature. I work for Director Jim Carroll, who leads our team at the White House Office of National Drug Control Policy, our nation's drug czar. He, as well as myself and several others on our team, have really been doing a lot of stakeholder outreach over the past couple of weeks with calls to our treatment and, for myself, our rural partners. Some of what we're hearing for those who are either themselves impacted by OUD or who are in families where this is an issue, some of what we're hearing first for individuals are that people who are in recovery, even in long-term recovery, several years into their recovery journey, are relapsing. We've heard a number of accounts of suicide, 2 suicides that we learned about in the Appalachian region. One was a person who'd been struggling with SUD combined with depression for several years, and another was the suicide of a young man who had been in recovery for several years, had a brand new infant child, and had lost his job due to COVID. And the anxiety, the financial pressures coming from that loss were a big challenge for him. We're also hearing anecdotally of surges in increased use of alcohol consumption. With respect to families, a couple of trends here, really hearing from our law enforcement partners about increased calls regarding domestic violence. And then with respect to children, I was on a call a couple of weeks ago with a drug court judge in rural West Virginia, and he talked about how the numbers of reports that he's receiving with respect to child abuse and neglect are down. But honestly, that's what's keeping him up at night, because he knows of the stress and the tension that is in these homes. But because schools are closed, and those are typically how he learns about these situations, being a mandatory reporter, the calls just aren't coming in. So that's some of what we're seeing.
Very good points. Yeah, and the interface with other mental health issues is really profound, and the feelings of isolation and anxiety and really exacerbation of depression. I think many of these things nest together. So, Regina, would you like to speak to the general topic of how the pandemic has impacted the OUD epidemic so far?
Sure. So I think, as Anne mentioned, a lot of what we have are anecdotal reports right now, but they are of grave concern. I think a couple things. One is that Dr. Nora Volkoff, who is the head of the National Institute on Drug Abuse, put out a blog a couple weeks ago talking about the specific at-risk population, people with substance use disorders, people with opioid use disorder, because of pre-existing conditions, co-occurring disorders. COVID is a respiratory illness, and the interaction that respiratory disease would have with opioid use disorder and other substance use disorders puts this population at risk. There are over 20 million people in this country who have a substance use disorder. So while the nation's attention is focused on this important disease that we're seeing, we have to remain, we can do these two things at once, which is pay attention to the nation's substance use disorder and opioid use disorder while also caring for people with COVID. And that's the challenge before us. And actually, I think that while it looks like we're not, like the nation's attention is diverted, I actually think it's not. If you talk to the people who are working on a day-to-day basis, this is directly before them. A lot of attention's being paid. Much more needs to be done, but there's been some really important attention paid to this at-risk population right now.
It's a perfect segue, actually. Thank you for the second question, which is really about access to treatment services for people with OUD and SUD. A number of different changes have been made to SAMHSA regulations, DEA regulations, and other regulations that have actually impacted, in a positive way, impacted the access to care. So I'd like to just pose a question: what are we seeing with respect to access to care? How is it working? And maybe Anne, if you want to speak to this first, you can maybe address some of the changes that were brought forward and how they're working, and we can then provide some different anecdotes to maybe fill in some of the blanks and provide some commentary on those topics.
Happy to. Thanks, Rob. I think Regina really spoke to the heart of the issue of concern about this vulnerable population of people who have a substance use disorder, being vulnerable both to the virus itself and then to the relapse that can come in their recovery during COVID. So much of the focus of the administration and the federal family during this time has been to ensure from the start of this public health emergency that there be flexibility in agency policy as well as resources, whether it's information or dollars, to make sure that access to treatment is available and doesn't lapse. Not only treatment, but the recovery support that's needed as well to keep people from relapsing during the pandemic. I'll attempt just to hit the highlights of some of the changes that have been made. And in addition, ONDCP has produced a fact sheet, which I believe Tony is going to put a link to, that might help folks keep track of some of what has gone on. In the area of telemedicine, we've made some huge steps here to be able to expand the use of technology for folks to access care. DEA and SAMHSA are allowing providers to prescribe medication-assisted treatment to new and existing patients, both through telehealth and over the phone. DEA has been allowing its providers with that DEA license to prescribe to patients that are even outside of the state where they are registered. And that, again, is allowing providers to work across state lines through telemedicine. And then lastly, CMS has done a lot of work really to expand the coverage of telehealth services, both on the Medicare side and then encouraging states to do the same with Medicaid. They're allowing opioid treatment programs to provide counseling using telephone calls rather than the two-way audio video technology typically needed. And that for people living in rural communities is very helpful because that technology might not be available. In addition to telemedicine, there have been changes to ensure that there's continued access to medication-assisted treatment. For methadone, for example, SAMHSA is allowing states to authorize an opioid treatment program to give stable patients up to 28 days of take-home doses. And for a patient that is less stable, we are still seeing 14-day take-home doses. In addition, DEA is allowing methadone to be transported to a patient who can't actually get into the clinic. And then finally, in addition to telemedicine and access to medication-assisted treatment, CMS has really been providing flexibility to states in the use of their Medicaid resources through what's called the Section 1135 waiver. And that waiver can be used for a lot of things, but it is another tool, again, to expand the use of telemedicine. Again, I think that's a lot to keep on top of, and so I'd encourage everyone to look at the fact sheet that ONDCP has put together on these issues. Some of the anecdotes that I can share that we're hearing from some of the treatment and recovery facilities that we have been able to talk with, on an encouraging note, hearing that treatment line calls are up. Admissions for those facilities that are able to keep taking new patients are also up. I also have talked to some treatment providers that have seen a real surge in the rate of appointments that are being kept because much of this work is being done through telemedicine, and that technology really takes away two of the biggest barriers, especially for people in a rural community, for showing up to get help, time and then transportation. I think on some of the challenges that we're seeing with accessing treatment, for those facilities that are offering transitional housing, many people that are living in that housing who are in recovery and have a job can't pay rent anymore because they've lost their jobs due to COVID. So creating that housing instability that we know is very important to maintaining recovery. Some of the facilities that have social enterprises as part of their organization, some of the business work from those social enterprises isn't happening right now. If it's a landscape business or a moving company, metal recycling, with that lack of economic opportunity, some of the funds for future treatment and recovery activity is uncertain. We're also hearing anecdotally of recovery facilities that have been closed due to a positive COVID test, either with residents or the staff, and that leaves people who are in recovery with no place to go, and especially dangerous for somebody that needs to maintain that separation, perhaps from family or previous community that was not healthy for their sobriety. With that, I will hand this back to you, Rob, for some other insight.
Yeah, no, excellent comments, and really appreciate that insight. Regina, do you want to respond to this question next?
Yeah, I think as Ann said, there are a host of regulatory revisions that have been made, and SAMHSA and DEA and the federal government has been extremely responsive to the needs of this population right now. And under the public health emergency, the HHS public health emergency. I think it's important that as we think about access to treatment, so of the, about there are about 11% of people, according to National Survey on Drug Use and Health data, who have a substance use disorder who receive treatment. And about 30% of people with an opioid use disorder receive treatment. So this allows us an opportunity to look for new ways to have kind of a natural experiment and a pilot to figure out how can we reach people? Because when we think about how to address COVID-19 and people with opioid use disorder, we need to think along the continuum of people who may not yet have entered treatment, who are interested in going, who may not be able to access treatment in a traditional way. So this allows us, perhaps we have an opportunity to really rethink our approach and to look at what's going to work for more people to make sure that that treatment gap gets lessened. And also, and I know you're going to talk about this later, but also to think about people who have opioid use disorder, who, how do we keep them safe? And how do we make sure that any use that they currently have, that we make sure that they get the naloxone, that they get the syringe services programs that they may need. So I think I'm hearing some really positive things from people in the treatment field. I'm also hearing some concerns about, you know, they are healthcare providers and they are on the front line and they may not have access to personal protective equipment because that's just not traditionally what that type of clinic that they have that. So those are, you know, we have to think of these facilities as healthcare facilities that treat the whole person, that they not only treat people with substance use disorder, but also people who have other conditions, which may be kind of complicating factors for treatment. But you know, there's the other piece of this in terms of treatment access that we can't forget is that there's a shared responsibility. The federal government has put out a lot of guidance, a lot of new regulations that are reach more people, but at the same time, states also have play a very important role in access to treatment. And those vary, they have varied in terms of the flexibility. So, you know, 50 states kind of on top of or underneath what the federal government is doing.
Yeah, very, very good point. Brandon and I happened to be on a call yesterday with a state in the Mid-Atlantic region, and we were discussing the impact of these different regulations. And one of the things that was interesting to me was that the counseling requirement for that particular state and for buprenorphine focused medication for opioid use disorder clinics, the counseling requirement was waived effectively for that state. And in other states such as mine, that isn't the case presently. So it provides an opportunity for some evaluation down the road, and we'll discuss that in a few minutes. But you know, I think some of the advantages that I've heard relative to telehealth, I mean, I have a colleague here in Tennessee, Dr. Stephen Lloyd, nationally known expert on this topic. He's providing buprenorphine MAT in his clinics, and for which he's medical director, and says that the opportunity to actually see the home environment via telehealth and actually experience, you know, some of what the family is experiencing around them has been very valuable. And he also commented to Ann's point earlier, you know, that appointments are being kept. And that's a really good thing. It's a really positive thing. Conversely, we were discussing this informally recently and had a conversation about a state where, you know, dozens of clinics had to shut down because they didn't have the telehealth capability. So I think that's a real downside, and we need to be mindful of that. And I guess just try to help those who are affected by that gain access to other resources. Okay, so Brandon, do you have any comments to that, or you just want to move on to the next question?
I would just quickly add, Rob, that many of these changes, like moving over to telehealth, mobile transport of methadone, in many ways they're more patient-centered and are reducing barriers like transportation, which have been in place for a long time and which were affecting many folks' ability to access treatment, like Regina stated. So I think from a research perspective, it's up to us as the research community to evaluate these changes, understand which ones work, whether there's any potential downsides, describe those, and then, for those that work well for most people, advocate that some of these changes become permanent.
It's a great point. And earlier this week, when we were discussing this together, the point was made that we had an existing public health emergency related to the OUD problem, but we hadn't yet made these changes to access, but they are actually welcome at this time in response to this global pandemic. So Yeah, I think your point is very well made, Brandon, that we need to evaluate these things and see the extent to which, they provide extra value. Different regulations provide extra value and prevent and or facilitate what they are intended to do. Let's see. So the next question is, so the modifications that Sampson and the DA have made have not been really open for use. The modifications haven't been in place for very long. How are we going to evaluate these? This is the question. So what are the tools and techniques that we have to evaluate whether or not these different changes in regulations are impacting the problem? And how are we going to do this, and to what extent is there some sort of harm to the existing systems that have been in place for a while to monitor progress? Regina, you want to take this one first?
Sure. So I think as we're my understanding is that that CMS is looking at some of the impacts of the policy changes, and that they'll be doing some evaluation. As Brandon said, there'll be research that will be done, and that will drive and inform some of the policy change. The challenge is sometimes that the policy changes sometimes come before the research is able to inform that policy change, and that's going to be a big challenge here. So, I know that there are some groups that are doing, like the National Council did a survey of their members. There's a lot of initial surveys that are going on to help inform any additional policy changes that are made. I would say that it will be very important to be mindful of the patient view of any of these changes. So as we're evaluating things, we need to absolutely, talk to the treatment providers about what they're seeing and have the general mechanisms by time in treatment. That's usually how the success of treatment is evaluated. We also have to look at the patient experience and whether or not that individual is having gradually improved outcomes. And there are lots of groups such as Shatterproof that's working on how to evaluate treatment better. But there'll be a huge opportunity for researchers to look at this natural experiment and the pilots. So I actually think we need to look at this as a series of pilots. It will be different in the rural parts of the country versus the urban parts of the country. We tend to often think of the importance of telehealth is certainly very well known in rural areas, but it's also important at this time in urban areas where you could still have a long way to travel on public transportation to get to your methadone clinic once a day. That's a barrier. You may have childcare needs. That's another barrier. So as we evaluate these programs, we will have to look for long-term outcomes, but also in the short run, make sure that any evaluations help inform sound policy changes that are made in Capitol Hill and in state legislatures around the country.
Good. Brandon, do you want to speak to this point?
Yeah, thanks, Rob. So I've been interested for a while in understanding how we can use administrative data collected at a state level to evaluate our response to the opioid crisis broadly. So fortunately, at least here in Rhode Island anyways, we've set up a lot of those systems. And I'm optimistic that we'll be able to leverage those to understand the impacts of COVID-19 and some of these regulatory changes on access to treatment, retention, and care, and so forth. Earlier last year, we published a study showing a baseline continuum of care for people with opioid use disorder in Rhode Island. And so that will provide, for example, a baseline understanding of how many people are accessing treatment or diagnosed, accessing treatment and retained. And then we'll hope to continue using those same data systems to see the extent to which some of those care continuum outcomes change as COVID-19 unfolds. So from a research perspective, if we can use some of these administrative data sets, PDMPs, state treatment admissions and discharge records, those are going to provide, I think, a lot of understanding for us on what the story is ultimately, and can use those, I think, effectively, in say like a quasi-experimental or natural experiment type approach anyways, to try to evaluate as best we can the impact of these regulatory changes on patient outcomes.
Yeah, very good points. So what about the disruption in surveillance systems? Brandon, you and I have spoken about that earlier this week, and the issue that I think, this has been such a dramatic disruptive pulse through all systems, this COVID-19 pandemic has, that things that have been working for a long time may even be disrupted, such as national surveys, things of that nature. Do you want to speak to any of those issues?
Sure, Rob. So that's been something I've been concerned about since this pandemic started to unfold. We're seeing, I would say, reports in the media, some initial reports from local and even state authorities that overdoses may starting to spike or be increasing. It's really too soon to determine whether those reports are evidence of a broader national trend. And that probably won't be available for some time because some of those national reporting systems around overdose are delayed, often by months or even up to a year. But what I've been concerned about is that some of our surveillance systems themselves may actually be affected by COVID-19. So the ability to accurately map some of these changes are going to be compromised if our surveillance systems are compromised. So there's been concerns reported that coroners and medical examiners overwhelmed with cases in some jurisdictions. They might not have the resources to follow up on overdose deaths. So it's possible that overdoses may be underreported. I know here in Rhode Island, hospitals are struggling with a crush of COVID-related cases. They may not be reporting overdoses to the same degree of fidelity as they were in our hospital-based surveillance systems because of that. And finally, there's concerns that overdoses that are happening out there in the community are maybe less likely to result in someone presenting for care at an emergency department because they don't want to go. They're scared. They don't want to go to the emergency department. So in fact, overdoses could be increasing, but we might not see that because some of these changes and behavioral changes among people at risk for overdose. So we as a research community have a lot of unpacking to do to understand whether some of the trends we're seeing are true or whether they're spurious as a result in this sudden disruptions to the surveillance systems.
It's an opportunity as well, I think, for maybe some mixed method studies where we can begin to both speak to people who have opioid use disorder, but also those who may be in a situation where they're disseminating naloxone. For example, in our state, our regional overdose prevention specialists are naloxone distributors, and effectively, they would have an idea about uptake in use, or I guess upticks in use, and maybe any kind of surge in that space. So just so many different questions are rising from this interface between the two epidemics. Anne, did you want to speak to the last issue? The last question about modifications to regulations and sort of how things are being evaluated? before we move on? I want to
Yeah,
dive in a little bit more after that into overdose fatalities. So if you want to speak to the other issue, that'd be great.
I agree with much that has been shared by both Regina and Brandon about evaluation and the importance of it. This is such a unique time. Let's hope it's a unique time that something like this of this magnitude does not repeat itself. And we are been given a rare opportunity to evaluate some of these policy changes, and speaking specifically through a rural lens, which is my portfolio. Much of what has happened in the past 6 weeks are changes that have been considered and debated long before the pandemic, years before the pandemic. So, we understand that evaluation of the impact of these temporary flexibilities, whether it's a positive impact or a negative impact, is a critical step before decisions about policy changes can be made. Regina mentioned CMS. We are strongly encouraging agencies who have that capacity to conduct these evaluations. And of course, this work will then all be coordinated across the interagency. Thanks.
Yeah, thank you very much. So some different colleagues have asked, if we wanted to advocate for these modifications to be more permanent, how would we do so? And what do you think about that, Anne, in terms of like the best way to maybe communicate positive changes or negative consequences from any of the different regulatory changes?
I think there's a number of different venues, and that process will become more clear here in the coming days. But some of the changes that we would like to see permanent may take a statutory change. Others will be at that agency level. And so I think to the extent that people are communicating both on, in the legislative branch as well as the executive branch, those are two important audiences to keep in touch with. In addition, Regina touched on the role of the states and how the states execute some of these opportunities down into their own communities is another very important partner to keep coordinated in this effort. Thanks.
Excellent points. Okay, so relative to overdose fatalities, we know that the systems they take some significant time to I guess overdoses take a significant time to kind of work through the system and then be reported by the CDC and back to the states. That's when we don't have a COVID-19 pandemic happening. The disruption of all of those systems at this point is leading us to try to figure out what's going on with both, I guess, overdose hospitalizations and fatalities and other aspects of this disease. It's leading us to really have to patch together different pictures, different vignettes, if you will, of what's happening. And that's not a very systematic way of going about it. For example, anecdotally, we hear about some funeral homes not having any overdose fatalities, and yet we know that in that particular town there are overdose fatalities, and how that is all working together. Do you want to speak specifically to any other issues related to overdose and the systems and the tracking and evaluation? Brandon, I'll pose the question first to you.
Sure, Rob. I would just highlight how challenging it is and will continue to be to accurately count and ascertain the causes of death in this kind of crisis. You and I were talking earlier on a different call about the fact that, as Regina mentioned, this is a respiratory disease, right? And so if someone is using opioids, be prescribed or illegally obtained and have COVID, it may be hard to differentiate the driver of the cause of that death, be that the disease itself, the opioids on board? Did they interact in some way? So I think it'll take some time for us to fully grasp, I think, the scope of the magnitude of COVID-19 on mortality, and also how overdoses are changing in that context, because it is a very challenging etiology to fully disentangle. So we've got our work cut out for us, that's for sure. And I think the more systems we can rely on, the better. You know, EMS calls for overdose could be one data point for us to examine. And like you said, talking to frontline staff, harm reduction providers, syringe service programs, naloxone organizations, getting a better sense of what's actually the picture is on the ground will be incredibly helpful. And some of that research is already coming out already. Organizations like the Harm Reduction Coalition have put out great information on how this crisis is affecting harm reduction work broadly. So I think we'll get there, but you're right, it might be a patchwork, at least at first.
Any other comments related to that topic? We have about 20 more minutes and a few more questions here. The first of the, I guess the remaining questions is, so there has been, you know, significant funding for opioid use disorder treatment, prevention, education, other activities, and dissemination of evidence-based approaches to address it for quite some time. How do you think the pandemic is going to impact that funding and those activities sort of at a more of a system, I guess, federal system level? And so I'll pose the question first to Anne. Do you believe that we're going to continue to see you know, sustained funding to address the OUD crisis, or what's going to happen relative to this issue?
Thanks, Rob. Let me speak first from the perspective of ONDCP and then perhaps a bit more broadly. At our agency, we are truly full steam ahead on the addiction crisis. You hear it described that this is now the epidemic within the pandemic, and the public health emergency from the opioid epidemic hasn't left. While we have made some progress on this front, we are still losing nearly 70,000 Americans each year, or 200 people a day, to the disease of addiction. And in this work, in this challenging time of the pandemic, we are doing our work differently, but all of us remain on that mission every day to save lives. I think certainly we will see a competing need for resources, especially when you look at some of the core partners that we do this work with at the local level, at the state level. Many of them are now going to be facing challenges in their own budgets. But I think from all of the conversations that I've had with those type of partners, the intensity of the focus on the opioid, the broader addiction crisis has not changed. We simply will need to be innovative and build new partnerships to do our jobs to save lives. I want to touch briefly, I guess more broadly, on something that I think Regina identified in the beginning of this discussion, is that if anything, I think the pandemic is really putting a spotlight on the mental health needs in our country. And of course, all of us working on the addiction crisis know of that interplay between mental health and addiction. And so we are full steam ahead. We'll just be doing our jobs perhaps in a different way until life goes back to more of a normal cadence.
Thank you. Thank you. You know, your comments made me reflect on the, you know, some of the key partners in our state, for example, are hospital systems. And when hospitals have shut down, they really, not shut down, but when they have stopped doing things like elective surgeries and things that create revenue, and you know, it puts a lot of other activities at risk, and they can be significant economic drivers for the for their towns and regions. And so not only that, but also the tax receipts in communities as well as in states. So yeah, the long range impacts of this pandemic are really tremendous. Others, Regina, do you want to speak to this issue of funding and what might happen hereafter?
Yeah, so I was just reading an article that estimates there'll be 11 to 23 million more people on Medicaid this year.
Yeah, I haven't seen
So
that.
we can't underestimate the fiscal impact, and I have no doubt of the commitment that has been made by the federal government and many states to fund addressing the addiction epidemic. I mean, the federal government has put forth billions of dollars to states. I think going forward, because of this fiscal emergency we're about to enter, it will become even more important to be very targeted. And, you know, I worked for the city of Seattle during the economic recession that we faced in 2008, and it was pretty devastating to the city's coffers, and we had to make very difficult choices. That will be the theme going forward as state legislatures put together their budgets. You know, New York State just announced cuts. That's an area that is going to be very much in play over the next couple months. And I know there's been a request made to the federal government to add $38.5 billion for local treatment facilities. That request was just made recently if there is a COVID-4 package. So, just fiscal pressure will be ever present at every level of government.
Yeah, I think you're right. Other comments, Brandon? You want to speak to this issue?
No, I think Ann and Gina hit it on the head. So maybe let's move to the next question, Rob. Yeah.
So very disruptive events such as COVID-19 can reveal deficiencies in systems, and I'd like to begin to think about at least maybe a positive point to close our Q&A down with. Are there any obvious opportunities for improvements that we've been able to discern from working through this topic both today as well as your other thinking? So improvements to systems, improvements to policies, things of that nature.
Rob, I wanted to talk a moment on that note about syringe service programs, that provide life-saving services every day to people at risk for overdose, naloxone, sterile syringes, access to treatment. And on the downside, there's recent research suggesting that many of these programs have had to decrease availability of services. One study that I'll provide a link to maybe to folks by Sarah Glick showed that 1/4 of all syringe service programs had to close at least one or more sites due to COVID-19. So that was research that just came out. And also people that work at syringe service programs, many of whom are peers or people in recovery who have chronic conditions themselves and are at high risk for complications due to COVID-19. So it's a really tough time for syringe service programs right now, and I think it highlights the thin margin that many programs across the country were operating on extremely low support in terms of funding. But to get to the second point of your question, we have seen some pretty rapid innovation in the provision of services. Many programs have increased the amount of supplies that they're providing to clients to reduce the number of interactions required, relaxing restrictive exchange policies, providing access to buprenorphine over telehealth, like we were talking earlier about, and coming up with innovative delivery models, mobile services to people who are sheltering in place or at home and at risk for overdose. And in many ways, many of these models are considered best practices, and I think they will save lives. So hopefully that might be a small silver lining in all of this. It's sort of going back to that earlier discussion around treatment, that maybe some of these changes are actually better practice and will be maintained and improved once COVID is no longer with us.
Thank you. Yeah, good thoughts. Regina or Ann?
This is Ann. I can touch on this question through the lens of rural communities. I think that the impact, the potential impact of the opportunity that has been created by COVID for telemedicine cannot be overstated. At the same time, with the use of telemedicine, people attempting to work from home and all of the distance learning that is going on for rural children, COVID has also really highlighted the need for additional focus at the federal and the state level on building the broadband infrastructure that we need and the capacity on how to use that technology in communities to build these virtual systems. Many people would like to live in rural America, but need to be able to make a living, raise a family there. And so the more connectivity that we can build to these places, that's so important to the future of many of those communities. In addition, on a positive note, I think that the use of telemedicine really raises opportunities and new thinking about the future needs that we have for healthcare, the healthcare workforce in rural communities. Having people and doctors and all of the support staff that are willing to go work in a rural area has been a longstanding challenge. But one of the things that I've heard from at least one rural treatment provider that has been expanding rapidly in the Midwest and is now all in with the telehealth changes, they have really stepped back in the past month, and as they're thinking post-pandemic, and are recasting the vision that they have as they grow, really for the positions that they need to actually fill with a physical person in the rural community that they're expanding into. They have a lot of transitional housing, so needing a recovery residence manager to be on site in that facility is not going to change. That's a person that they need in person. But if we have this ability to do so much virtually, are some of the other positions that they also need to fill, can that be done with someone who is in an urban setting in that urban center and is able to connect remotely? That's an opportunity, and one that is very exciting to think through.
Thank you. Yeah, good point. Regina?
No, I think that Brandon and Ann handled it perfectly.
All right, so in the interest of time, we've got about 7 minutes left, and we have a number of comments and questions. Before I move to those, the last point I wanted to make was about how the COVID-19 pandemic may impact the MDL, potential for MDL litigation to begin to resolve itself, sooner rather than later. And as of now, I believe that things have been pushed into the future for quite some time. And so just given the way the courts have been mandated to run and so on. So I think we know the answer to that for now. Things have been moved on down the road for a little ways. And I think that we can move past that question. But the couple of comments that have shown up in the Q&A I think are really interesting that I just want to address. David Cunningham from Tennessee, over Middle Tennessee, actually has made a comment about online support group attendance, which is something we didn't address, and I think that it's really important. He comments about the fact that the online support group attendance has increased locally, regionally, and nationally, and that's been a real lifeline for some folks. That's a positive, against the negative of just the general isolation of having to be at home and so on. But a lifeline it is, and David, I appreciate you bringing it up. Let's see, that's a comment that has been addressed. Richard Taylor, also from Tennessee. Tennessee's showing up today. Thanks, folks. Anyway, Richard has asked the question, how can regions and communities start to come together to form task forces or coalition to address the impact of COVID-19 on SUD treatment and recovery? I think it's just, that's just a matter of being the person that takes the lead, you know, being the person that basically convenes the coalitions and begins to energize that topic. Because I mean, you know, all of us have that ability and responsibility in some ways. And so, Richard, I really appreciate the question, and I think it's just a matter of convening people on this topic and beginning to have, you know, these thoughtful dialogues, and then looking to get to the next question, which is I think also very, very compelling. What is what's going to happen after the pandemic ends relative to SUD treatment? And so that's a question I'd like to pose to you, our panelists. I mean, after this is over, what does the aftermath of this look like? And thank you, Olivia, for bringing this forward, because I think it's a very compelling question. So say we knew definitively that this one was over, this pandemic of COVID-19. And, you know, I think that's somewhat challenging to think about today, but once we think we're out of the woods on this one, what does the aftermath of that look like? I think we've addressed the topic of funding already, but are we going to see the same scale of infrastructure that we have now? Or what are the impacts of this?
This is Ann. I can go ahead, Regina.
Well, just two quick things. One is I think that we may see a shaking out of some treatment facilities, some local treatment centers, and that's something that we need to be aware of and make sure that we don't shrink capacity. But at the same time, I think it will be difficult to kind of go back to the status quo. And that I think that, you know, there are lots of national organizations. It's good, as I did a webcast last week with the Mayor of Huntington, West Virginia, who said it's incumbent upon each of us to be leaders at this time. And there are national organizations like Shatterproof and Faces and Voices in Recovery and Young People in Recovery. They help organize people nationally, but also every community could have their own show leadership on this issue and make sure we don't go backwards in terms of some of the progressive steps that have been taken to make treatment more accessible.
Very good points. Ann?
I think the evaluation of policy, what stays and what goes, we've already touched on that, but that's an important piece. I mentioned some of the needs in infrastructure, specifically the broadband infrastructure that this has highlighted. I think this galvanizes a conversation about that need in a new way as we come out of this. Two pieces that haven't been touched on. When I think about, and again, I'm looking at things through the lens of rural, but I think you could take this into, you know, urban and suburban economies and communities as well. When we think about the economic recovery of this, I think of a vulnerable population will be people that are in recovery and may have a background, a work history, or a criminal history that is challenging. And pre-pandemic, with the way the economy was rolling and going, from what I saw on the ground, there were many businesses and state chambers that were stepping up to find recovery employment initiatives, in part because the economy needed the workforce. And I think as we find ourselves in a different posture post-pandemic, really finding those ways to be innovative and help people move into that employment that they need to maintain their sobriety and build that life that they were meant to live is going to be incumbent upon all of us. Lastly, we haven't talked today about the faith-based community, and I think that is such an asset in many places that is still yet to be tapped around the addiction crisis. And when we think about the attention that the pandemic has brought to mental health for many people who maybe didn't think they had addiction in their congregation, but they can see they've got a mental health stress challenge in their congregation because of the pandemic. Let's use that awareness as a chance to build a bridge to the way that we need that asset in the addiction fight.
That's a great point. It's a significant asset for many in our country and in certain specific regions for sure. So Brandon, do you have any other thoughts? We have about 1 minute left, I think.
Yeah, I just, one thing we haven't talked about today are racial, ethnic health disparities, which I think this pandemic has exposed so much, and we deal with a lot in addiction. The history of this epidemic is woven into the war on drugs and racial ethnic health disparities. So what I worry about is that we're not going to take this as an opportunity to fundamentally address those in this country. I really hope we do, and I hope this has exposed those to just such a degree that responding and addressing them is untenable. So that's my hope, Rob, coming out of this.
Thank you very much. Any final comments, final thoughts before we turn it back over to Tony? Okay, well, thank you so much. I can't tell you how fun this was to both put together and participate in, and really appreciated all of your input, and thank you so much for your time. And thank you to the participants as well. Tony, not the participants on the panel, the participants in the audience. Tony, I'm gonna turn it back over to you at this time.
Great, thank you. And thank you to all of our presenters and Dr. Pack as well. Please, at your convenience, take a look at the task force report, which is located on the ASPPH website. At the end of this session, a recording will be available. Two things. One, the recording will be available of this webinar shortly. But secondly, when the webinar closes, a session evaluation link will appear. Please fill that out. We really do appreciate your comments and feedback. Lastly, please do check out the ASPPH webpage. Our members have been incredibly engaged, both on the COVID-19 issue as well as on opioids. And there are a variety of stories about what our schools and programs are doing that are available on our website. And lastly, there are 2 final webinars in the ASPPH virtual annual meeting. Next Friday at 1 o'clock, the concluding session of the virtual annual meeting will be a conversation with Tony Fauci, as well as lessons learned by academic public health leaders during the COVID-19 pandemic. So thank you to our moderator and presenters, and thank you for attending today's webinar. Have a great weekend.
Take care. Have a good one.
Thanks, everybody.
Thank you.